We are live. Good evening, everybody. Happy Saturday to all those who are tuning in. I have a very special guest on the show tonight. That was one of my very first live stream guests about 5 years ago. So this is Dr. Bob streaming with Matt Forney tonight. So you want to say hello to the audience, Matt?
Thanks for having me on, Dr. Bob. And yeah, 5 years. I mean, I can't remember the exact time we did the stream, but yeah, that sounds about right. But yeah, it's good to be talking with you again.
Yeah, that was, I believe it was June of 2020. That was at the height of COVID. And I think we were all locked into our houses or apartments or wherever we were at the time. Were you still in Eastern Europe?
Yeah, I was in Albania at the time. Because I'll keep this real brief. But I decided to take a road trip across Europe while I was in the middle of moving to South America, which began in March of that year. I made it. I spent a week in Greece, and I made it to Albania before the borders were shut down. And the rest of that year was. Well, it was not great, but I won't go on. I won't go on about it because there were a ton of people who had it way worse than I did.
Yeah, I know that was such a crazy time. I was engaged at that time, but then after I got engaged, I remember I went to go see my fiance at that time, who is now my wife, and she was living across the country, and I went to see her in March of that year, and that's when I was at a medical conference actually in California, and then flew to go see her in another West Coast state. And I got back on Monday, and I remember it was that Wednesday, since this is a stream about healthcare that we're going to talk tonight. I remember the sheriff's deputy there in North Carolina, where I was at the time, walking into the gym where I was working out at like 6 or 7 a.m. in the morning. And there was a guy who was deadlifting, and he was mid deadlift. And the sheriff was like, pack it up, close it down, health order from the governor. And, he was like, you got to be, joking. I remember the sheriff's deputies came in, and they told the gym owner he had to close everything down. So that's one thing we'll get into tonight is just the decline in trust that Americans have in our medical profession and our public health profession, especially post-COVID, and just the inability of much of the healthcare establishment to recognize the fact that they are disconnected from the average American, and it's had disastrous consequences for our profession. So tonight, stream is entitled "American Sickness: Discussion on U.S. Healthcare." We're talking about the very many troubled headwinds that faces healthcare in the United States. And Matt, did you want to sort of share the tweet that kind of, I guess, launched this discussion? I think you posted it about a week or so ago about foreign physicians in the United States, because I believe you were responding to somebody who was talking about how xenophobic it was for us to have protectionism of the medical profession in the U.S.
Yeah, I mean, I'll try and pull up the exact tweet. I don't have it on me. But basically, I talked about the experience. Not me, but someone close to me had when I was growing up with an Indian dentist who was ended up getting convicted of medical malpractice. Now, what she did to my friend, what she did was falsely claimed that she had 6 cavities when she didn't have any, just so she could bill for more medical work. What she actually got in trouble with the law for was, among other things, leaving parts of tools in patients' teeth after operations. There were several cases where she fractured patients' jaws while she was extracting teeth, like that kind of thing. And as I recall, she got off relatively. Okay, I found the tweet. Basically, it was not the worst horror show, but it was pretty bad. This happened in upstate New York, and she ended up getting a relative slap on the wrist. She got $1,000 fine. Her license was suspended, and she was ordered to go retrain at the University of Buffalo. Um, a pretty mild punishment considering everything she got away with over like a 10-year period. Um, from my understanding, the DA's official excuse for not going all the way to stripping her of her medical license was that it was just a way too costly, expensive practice, and this was basically a plea deal. Like she pled down to some lesser charges and got off a lesser sentence so that the board and the local authorities could be like, yeah, we got the bad guy. We got someone who was harming patients. Um, this kind of thing is more common than you realize. Not you personally, but like the audience.
Yeah.
This is what happened with the mass entry of unqualified foreign doctors and medical practitioners into the American healthcare system. Uh, this particular woman trained at Bangalore College. Well, we all know there's been story after story of students at Bangalore College and other Indian universities like outright, plagiarizing, faking their degrees. We've heard the term degree mill, which is a very literal term in places like Ukraine, where you can just buy a PhD. Certain white nationalist did that, so he could legally call himself a doctor. But that guy, all he does is all he does is fleece people. When an actual doctor, like a medical doctor, does this, like it's very, very bad for patients. And I also mentioned in the tweet, I used to write. I used to work as a college ghostwriter. Uh, Basically helping students plagiarize. And we had a lot of medical and nursing students. Now, I don't want to oversell it. Like the vast majority of the work I did was in like humanities type stuff, like English, history, whatever. But there were a lot of like nursing and medical students who would outsource their work to these mills. To the point where they would just fake like labs and have ghostwriters do those as well. The ethnic breakdown on this is that, and this has been discussed going all the way back to Ed Dante, the Shadow Scholar in the early 2010s. The majority of the students using these services are foreigners, Indians, Chinese, Arabs, Africans. Um, Either because they just don't, they think getting a good grade is the same as actually doing the work, and they don't really have any moral qualms about plagiarizing. This has been going on for a very, very long time.
Yeah, no, it's interesting that you mentioned that that's the kind of work that you did. I remember how different my uh, application process for medical school was. I actually went and worked one on one with an English professor from the school where I went to college as I was getting ready to put my application together. And we worked on my personal statement for like a month and a half. And she kept telling me, to go back and do the revisions. And she made me write the whole thing myself. And, I think she ended up moving universities later on, but it was a really rigorous process of, editing and making sure that I was getting the themes of like why I wanted to be a physician and that kind of stuff. And for myself, something that, maybe for the audience and for you as well, um, I'm not only a first generation doctor, I'm a first generation college student. So neither of my parents went to college. They were both white, working class. of course, for all the white nationalists out there, yes, my dad is half Jewish, but that's another story.
Friendship with Dr. Bob over Deepak Reddy is my new best friend.
Yeah, yeah. So just to get all the the Groypers mad at me again. They got mad at me when I streamed with Kato on. I think we did a stream called Against Groyperism a few years back. That was pretty funny. But that's a stream for another time. But yes, I mean, neither of my parents came from money. My dad had to put himself through tech school, and my mom only ever got an associate's degree, and that was over like a 5-10 year period of like night school while she was working at the same time. So I didn't come from money. I went to State U, and my experience in medicine is it brings up a lot of complex feelings. I was waitlisted at my home state medical school along with 2 other schools, even though I had summa cum laude from a very, very prestigious public state university, and also well above average MCAT scores, above the matriculating average. And I'll just say that we'll get into it later on, that issues like the Bakke Supreme Court decision, I think, didn't fully deal with the issue of affirmative action. And so I had to go to a private medical school out of state, which has left me with a lot of debt. Though, eventually that's going to get solved. I think I did not have the advantages that certain people had. I remember there was a classmate of mine who was of a preferred demographic, and even though his parents were physicians, he had a full ride scholarship to the medical school that we went to. And he was a smart guy, did very well, but he was from kind of an upper class family, and probably didn't need to have the scholarship money, but and I think he ended up transferring out because he got married to a girl who was also a physician, which is another issue. It's tough to break into the field, and the trends that we are seeing right now, I think there is a real decline in competence within the medical profession. Both in people who are choosing to go into the profession, the way that training is done. And I think that's going to have some very negative externalities long-term for the U.S. So I was going to get into an article after this, Matt, but did you have any comments about that?
No, I pretty much agree with that. It's before everyone was watching, before we went on air, Dr. Bob was talking about how Obamacare regulations have basically wiped out the idea of the private practitioner. Pretty much the vast majority of doctors now are basically corporate employees who follow a corporate line, which has, if anyone is wondering why, say, during COVID, as we brought up, why every single doctor was like, yeah, put on a mask, do this, do that. But then suddenly when George Floyd happened, all of a sudden you don't have to isolate anymore because racism is a bigger public health crisis than COVID. And then all of a sudden they were, a year later they were like, take the vaccine. The vaccine is healthy. If you don't take the vaccine, you won't be able to go to the supermarket. It's because of changes like this. The industry has been, as you described it, it's been very heavily consolidated and corporatized.
Yeah. And here's I guess the first article I wanted to get into with you tonight. And that's this article here about why private practice is dying. And this is an article actually from 2016. So this would have been right in the middle of like the Trump election, right at the height of the 2016 election, which was very contentious. And so just to read a little bit at first is, there's a dangerous trend underway in American healthcare. And I'll say this is only accelerated since 2016. And that was the death of the private practice doctor's office. And this is a deliberate trend driven primarily by federal policymakers. It doesn't bode well for either the cost of healthcare or the health of individual patients. Policymakers in Washington, D.C. increasingly operate on the theory that large healthcare organizations are more data-driven, more efficient. Sorry, Matt, for laughing as I'm reading this, but I think everybody knows why. And more effective than their small private practice counterparts. This mindset has guided the creation of many laws and regulation, most notably the Affordable Care Act. Shortly after the law's passage in 2010, a senior Obama administration official told doctors that it would, quote, lead to vertical organization of providers and accelerate physician employment by hospitals and aggregation into larger groups. Here's the one: accelerate physician employment by hospitals. And the doctor writes, and I believe this is a Forbes article, I have watched this prediction come true from my position as a private practice doctor. Recent years have seen a stampede of my fellow physicians accepting buyout offers from hospitals and other large providers. The Physicians Foundation, which conducted surveys of America's doctors, found that 62% of physicians were independent in 2008. And that's the key year because that was the year that Obama was elected. By 2014, that number had dropped to 35%. So that's in 6 years. You went from 62% to 35% of physicians being essentially owners of their own business. A precipitous decline in such a short time frame. A 2012 survey by the Doctor-Patient Medical Association found that 95% of physicians see corporate medicine supplanting traditional private practice. And there's a number of different causes, but they talk about the first are the financial incentives that favor consolidation over independence. And part of that financial incentive, I think, is what he talks about next, which is Obamacare's increased regulatory burden. And I can go into some of the details in a little bit. And he said, these two problems are often related. For example, the Affordable Care Act made mandatory a number of cost and healthcare reporting requirements for physicians who see Medicare patients, which is about 90% of all physicians. Failure to comply results in slashed reimbursements rate that run as high as 6%, yet the additional administrative burden participating in these programs falls hardest on small private practices, which perversely are subject to the stiffest penalties. This obviously incentivizes private practice doctors to accept buyout offers from much larger entities. So does the steady growth of red tape under the law. At my practice, I've seen the costs and time requirement associated with regulatory compliance climb significantly since the law went into effect. It says, he continues on, and this is a big problem. The Affordable Care Act also pushes doctors to merge into so-called accountable care organizations, that's ACOs. These entities receive financial bonuses for doing the same work done in private practices. Doctors act rationally want to capture these bonuses and thus abandon their traditional business models. Sure enough, since 2011, physicians have flocked to ACOs with the creation of 744 such groups, serving more than 20 million Americans as the end of last year. And this is the question that he asked. So with all these changes, and let me get rid of this stupid advertisement over here. Does the death of private practice actually cut costs and improve quality? And the answer too often is no. And he cites this 2014 study that cited that small private practices actually have a much lower rate of patients going to the hospital with preventable health problems. And I think that's true that you have a physician who gets to know his patient and his patient's family over the long course of a life. You get to know that person. You can kind of get ahead of medical conditions, especially chronic ones. It says, then there's the cost. Hospitals and large practices have significantly more staff. This is a big issue right here. Infrastructure and administrative costs, factors that necessarily increase the price of their care. And they talk about the fact that hospitals receive much higher reimbursement um, than these same tests being performed in an outpatient setting. And I think it's true that the decline of private practice is really been negative, both on patient outcomes um, and upon costs in healthcare. And we can get into some of the administrative bloat later. So, what are your thoughts on that, Matt?
I mean, it makes perfect sense. It's the entire concept of regulatory capture. These regulations benefit large players at the expense of smaller ones because because like corporations are the only ones who can keep up with all the paperwork. It's like how I think they're called Altria now, Morris. All these big tobacco conglomerates favor increased tobacco regulation because it cements their position in the market. Like everyone's already buying, Marlboro or whatever. But so they don't have to worry about this. These companies have an oligopoly on this particular market. Who it hurts is any potential up and coming competitor who doesn't have the resources to comply with all these regulations. They just can't afford the overhead. And as someone who's run a small business myself, I understand acutely how these increased regulations just uh, they impact small businesses, private practitioners being a small business in the medical field more than anyone else. At the beginning of this year, there was a new FINRA, the basically small business owners, like anyone part of an LLC or whatever, had to go and report all the beneficial owners to the Department of the Treasury. This was implemented in that god-awful bill at the end of 2020, that huge appropriations giveaway, right
Yeah.
after Trump was defeated in quotes, basically, and the
No
penalty,
comment there.
yeah, the penalty for not complying with this was something like $1,000 a day or some ridiculous, or 20,000, something ridiculous. And the government, of course, was very vague on the implementation date. Now, this regulation never went into effect because a judge said, no, they put an indefinite stay on it. But that's just yet another example of how all this increased regulation just hurts the people at the bottom the most.
Yeah, no, I totally agree with that. Just a little bit of inside baseball as to what kinds of regulations have existed or came into being through Obamacare and the associated legislation. There was an act that was passed in 2009 called the High Tech Act. And this created a concept called meaningful use. You may remember from your childhood, Matt, because I guess you grew up in the 80s and 90s.
Yeah.
Probably, yeah, 90s kid like me. If you went to like a pediatrician in your small town or whatever where you grew up, I grew up in a suburb, outside of Atlanta at that time, and we had a small independent private practice pediatrician I went to, and all of the notes were kept on a paper chart. And so, they had a certain number of patients that they took in their practice, and everything seemed to work very well. I believe that physician, he was a good man, ended up going to be a missionary overseas after, getting fed up with medicine here in the States for a while, after a while. But you used to have these small, family practitioners, pediatricians, internists, OBGYNs, who would have just regular run-of-the-mill paper charts. And you had a much more personal connection with the patient at that time. I will also say the country was much more homogenous demographically in the early and mid 90s, which I think allowed for that kind of model. But there was an act that was passed prior to Obamacare, kind of in anticipation of Obamacare in 2009, called the HITECH Act. And it created this concept called meaningful use. And there was this push to have certain parameters that were met by electronic reporting. So we wanted to start computerizing all of our electronic or all of our medical records. So the rise of the so-called electronic medical record, and then later expanded into the concept of the electronic health record, or the EHR. You had companies like Epic and Cerner that came into being that kind of knew that all of this government pig slop was going to be coming their way. The so-called pork that you get in a lot of these bills, incentives for companies to, essentially get government cheese. And so what meaningful use did is that every private practitioner, this is not something that was optional. Every healthcare organization, every healthcare provider had to demonstrate meaningful use of electronic health records. And it was like a staggered implementation to where if you bought into, I believe, EHR technology by 2015, you got a lot of sort of incentives, discounts, and like government cash that would come your way in order to implement these systems. But if you didn't implement by 2015, then you actually started getting penalized for not having a meaningful use electronic health record. Now, here's the problem. If you're a large academic medical center, that has hundreds of millions of dollars or billions of dollars in cash reserves, you think of a place like, Massachusetts General Hospital, which is affiliated with Harvard or Johns Hopkins or University of Chicago, Stanford, places like that. You could afford these very complex, very difficult to implement systems like Epic. But if you were a small-time private practice physician, you could not afford to implement these systems. It was just too costly to be able to implement a meaningful use electronic health record. And so you were basically, via legislation, legislated out of existence as a private practice physician, because you just couldn't afford to implement a meaningful use EHR. And that's why a lot of these private practices ended up selling out to larger health systems, because they just couldn't afford to meet the meaningful use criteria.
Yeah, that makes perfect sense. I just going back to the whole regulatory capture idea, like you can take on these burdens as a large corporation. You really can as a small business, which is, again, that's just what a private practitioner is. Is medical small business. I was not aware of these specifics of the HITECH Act, but it makes perfect sense. And I do note, in the ghostwriting I used to do, I am somewhat familiar with the electronic health records, because there was a good deal of assignments related to how to handle those, which I mean the whole process of like large numbers of people who are potentially entering the American healthcare industry having plagiarized their work should make people feel very confident about going to the doctor. That makes perfect sense.
Yeah, it's whether Obamacare had this sort of pie in the sky idea that we were going to force through regulation young people to get health insurance. Basically, it was forcing people into a Ponzi scheme because there were larger demographic trends of an aging population. Yes, cue the boomer jokes. That we just we'll get into Medicare and Medicaid here in a little bit, but we needed more people paying into these essentially entitlement programs, and that was where the individual mandate came in, and also the High Tech Act with the HRs is that we were going to have all of this medical advancement and streamlining and efficiency because you would essentially have electronic exchange of health information. Now, the problem with a lot of that is that in order to do that, you have to create sort of an Orwellian surveillance state in order to make sure who is compliant and who is not. You may have remembered, wasn't that John Roberts who had one of his more controversial, probably legally tenuous positions was over the individual mandate? Do you remember?
Oh yeah. As I recall, it was like, it's the people who are arguing against it were like, yeah, it's unconstitutional. So John Roberts was all like, well, that's great. Let's just make it into a tax. If I may have gotten the details wrong, but that's what I remember.
Yeah, I believe he single-handedly saved Obamacare by saying he used a very novel legal interpretation to basically twist the individual mandate into, well, this is just a government tax, which was exactly what I believe Obama had said it was not when it was being implemented.
If it's not a tax, then why were people getting penalized on their taxes for not having health care?
Yeah, well, it's not healthcare so much, but health insurance. It was that's the sort of whole Ponzi scheme that Medicare and Medicaid is. But we'll get into that in a little bit. But the externalities of this sort of regulation where you're forcing everybody into purchasing health insurance, many young people who probably don't need anything more than catastrophic insurance, who are working, already being forced into the gig economy, where employers are no longer, giving people pensions and benefits and that kind of stuff. I think built a lot of resentment, especially people in our generation. You were, I guess, have been kind of in the gig economy for a long time, Matt. What is your take on sort of the disappearance of union jobs and the sort of health insurance benefits that employers used to give?
Well, like my observation is that I think the gig economy was in part creation of Obamacare. And in general, if you put the gig economy to the side, it's very difficult now compared to the 2000s to get an actual salary job with benefits where you don't have to do your taxes. Now everyone's an independent contractor, which they get paid hourly. They have to do their own taxes. Nothing's taken out, and they don't get any benefits. Like the last formal jobs I've had in the past 5 years, none of them were salaried positions. They were all hourly independent contractor nonsense. And the reason is because, Obamacare basically made having full-time employees just too expensive, particularly for small businesses. If the regulation is that, someone who works X amount of hours has to have health insurance, they're just not going to hire people for those positions. They're going to knock them down to hourly, reclassify them as independent contractors so they don't have to pay the benefits. They're going to, and in the case of like part-time jobs, they take the same amount of hours and then just divide them up among, two or three people. So the company that's employing them gets the same amount of labor. Well, instead of one person, working 30, 40 hours a week, now it's like, 2-3 people working like 20 hours a week or less. I remember I was in Iowa in 2016 covering the caucus, and the night of the caucus, I was with a friend, and we stopped by a convenience store, and my friend was asking the black guy at the counter, was like, "Are you voting? Did you vote in the caucus?" And he was like, "Nah, man. All I really know is like, I voted for Obama. I voted for Obama twice, and And when I first voted for Obama, I had one job, and now I've got three jobs, which kind of just sums it all up, really. It's basically the unintended effect of, or maybe it was intentional. I don't know. I can't read into the mind. I can't read the souls of men. The effect of Obamacare making all of this mandatory was just that nobody gets these benefits anymore. You're either in the gig economy, working for Uber or DoorDash, or if you have a job, you're hourly. Salary positions just really don't exist anymore.
Yeah, unless you have some sort of union job or you're a professional, whether that be a physician or a lawyer, engineer, something like that. And even then, it's it can be dicey at times. There were just so many unintended consequences. This sort of pie in the sky, I would almost say, New England Yankee idea that you can maybe implement something like this in a high trust, like Scandi Nordic, type country, but in a country as big and as complex as the United States, with as much, sort of local and demographic diversity that we have, it's just unworkable. And I think it is continued for all of the leftists who like to talk about income inequality. It's actually been, here's where I think the libertarians are right. In this particular area, I think regulation has actually widened the income gap.
Oh yeah, exactly. And it's worth pointing out that the entire structure of Obamacare. I wouldn't call it socialized medicine. I would call it fascist medicine, in the very literal economic sense, in that you, the consumer, are being forced to purchase a product from private corporations, which is that's the central element of fascism. It's not totalitarianism, swastikas, or whatever. It's the erasure of the distinction between the public and private sectors. And obviously, the insurance companies supported it, and they continue to support it now. Who wouldn't, back a government regulation forcing people to buy your product? Like, when I was running Terror House, imagine if there was a law like just saying that everyone in America had to buy like X amount of Terror House books. I'd be happy as a clam. I'd be making so much money. I wouldn't have to get on the internet ever again. That's and I don't believe systems like this are workable for the same reason you mentioned. America is just way too overscaled. It's way too big. And really, the socialized medicine systems don't even really work in the countries where they were conceived of now. Like Canada, because of all the Indians they've taken in, has massively overburdened,
Yeah.
primary health facilities. There was a case a few months back of a guy in Ottawa. He was some fitness influencer. He goes into the hospital. I believe he was saying chest pain. They treated him, discharged him, and told him to wait 6 hours for like a non-emergency physician because they were just that overloaded. He didn't want to wait, and he didn't know anything was more serious going on with him, so he just went home, and he ended up passing away because the hospital simply couldn't treat him in time because they've just got an infinite line of Ramesh's with runny noses going out the door. Same thing with the UK. People I know in Britain, it's like if you want to anything that isn't like an emergency, and by like emergency I mean like you got hit by a car, you're bleeding out onto the street type emergency, takes weeks or months to do anything. And another interesting fact is that the entire country of Canada has fewer MRI machines than the state of New York. That's not simply just a function of population. It's just how inefficient the system is.
Yeah, I actually had an attending of mine for my training program when I was still in training. She went to Ontario because I guess she had like a sister or cousin or somebody in her sort of near extended family who was living and working up there, and they had to go to a doctor's office. And she said it was like going to a delicatessen where they would hand out a number, but it's not like, a Jewish deli in New York where you may get your sandwich in 15, 20 minutes, something like that. I think she said they waited like 6 hours in the waiting room. And this was for like a routine, like primary care visit. And she said, this is a professor who I know, or an academic physician who I know, votes for a particular political party 100% of the time. And it was really interesting to hear even her, come to the realization that what is going on in Canada right now just doesn't work. I don't have anything pulled up specifically about the whole MAID concept in Canada, but from what I have heard in articles that have been passed along to me by friends of mine who are not in the medical profession, is that they are now starting to offer MAID much more commonly in Canada. And for those who don't know what MAID is, it's medical assistance in dying. It's essentially physician.
It's the politically correct term for euthanasia.
Yeah, euthanasia, which itself is a euphemism. I mean, it's murder by a physician. If we want to get down to brass tacks, where your doctor is basically allowed to kill you. It's not the idea of second intention, where if somebody has like terminal cancer and the doctor is just giving them lots of opioids to, sedate their pain, and that sort of secondarily takes them early. No, we're talking about people who have depression or people who are homeless. And I think it was something like now 3 to 5% of all deaths in Canada now are due to MAID. It's pretty horrific what is going on north of the border.
Yeah, it's pretty awful stuff, and particularly since they're trying to push it on people who are mentally ill, young people. Just saying basically, I think it's almost a way of trying to a very sadistic and bass-ackwards way of trying to lessen the load on the healthcare system by just getting certain classes of people to shuffle off on their own. It's like, well, like, it's too expensive. They're not going to come out and say like, oh, it's too expensive for us to give you medical care. We simply, so we want you to die instead. So that's basically that's what I think is going on here.
Yeah. So, Matt, I'll ask you a loaded question as we go into our next sort of related topic, downstream from the very negative thing that Obamacare and all the sort of downstream consequences of that. What would you say would be a good measure of whether a country's healthcare system is working well?
If people, again, life expectancy, I'd say.
Yeah, exactly. And with all of the technology that we have and all of the new regulations with meaningful use and that kind of stuff, do you think that has improved life expectancy, kept it the same, or has life expectancy in the United States actually decreased?
It's probably gone down. That's just a guess.
Yeah, I'll go ahead and share the next article, and this will lead into another topic immediately after this in terms of trust in physicians. So this is CDC data, and what's curious about this is I cannot find data that is more recent than 2021, 2022. That's very sketchy, and we can get into that in a second. But it says, this is from the CDC, so I mean, I'm going to a government website right here. Life expectancy at birth in the United States declined nearly a year from 2020 to 2021, according to new provisional data from the CDC's National Center for Health Statistics. That decline, 77.0 to 76.1 years, took U.S. life expectancy at birth to its lowest level since 1996. 0.9-year drop in life expectancy in 2021, along with a 1.8-year drop in 2020, was the biggest 2-year decline in life expectancy since 1921 to 1923. And they go into all the data. Basically, American Indian, Alaskan Natives had the biggest drop. I'll let you comment on that in a little bit, Matt. But also, non-Hispanic whites had the second biggest decline in life expectancy in 2021. One full year from 77.4 in 2020 to 76.4 in 2021. Non-Hispanic blacks had the third biggest decline, 0.7 year drop from 71.5 to 70.8. Life expectancy at birth was the lowest for both groups since 1995. Hispanic people had, oddly enough, a very low relative decline of only 0.2 years, and Asians, 0.1 years, basically the same. And they have the highest life expectancy. They say here, this is where I think the propaganda comes in. I don't think this data right here is accurate at all. They try to blame a lot of this upon the pandemic. It said COVID-19 deaths contributed to nearly 3/4 of 74% of the decline from 2019 to 2020, 50% of the decline from 2020 to 2021. An estimated 16% can be attributed to increases in deaths from accidents, unintentional injuries. And they said drug overdose deaths account for nearly half of all unintentional injuries. And they talked about all the various stuff. So do you have any comments on that, Matt?
It sounds pretty accurate. I mean, it sounds like obviously we've got the problems going on with the healthcare system, but also things like the COVID vaccine that are affecting people's health and just a general decline in the quality of life. So it sounds pretty accurate.
Yeah. There's a couple of problems I find with this data. As somebody who has a master's degree in this, in addition to an MD, two things. They talk about COVID deaths. Do you remember, Matt, all of the reporting problems that we were having in 2020, 2021, even into 2022 with reporting of deaths as COVID deaths?
Yes.
Yeah, I think there's this story of a guy who died in a motorcycle accident, but because he had tested positive for COVID, he was counted as like a COVID death. And there's a big problem in this data, and that's that when you look at quality life years, when you look at life expectancy, is there a greater loss of life expectancy in the general population when you have an 80-year-old who catches COVID and dies of COVID when they may have lived to be 82 or 83? Or is there a greater impact when you have a 30-year-old working a manual labor job who gets addicted to opioids and then dies at age 30 of an opioid overdose?
Yeah, basically everything was being. I know during COVID, a lot of basically if someone had COVID but died of something else, it was listed as a COVID death.
Yeah, the opioid. The opioid stuff to me, I think, is actually the bigger driver of these numbers. Because when you have old people who die, because we know COVID preferentially affected older people in terms of mortality, you're not going to get as big of a drop in the population if you have an old person who probably didn't have that much longer to live anyways, who dies of COVID, versus a young person during that time who got laid off, who got addicted to something, and then passes away when they're 30, 35, 40 from a drug addiction. There's a lot more life years that are lost in the population when the latter situation happens as opposed to the former.
Yeah, exactly.
So I think that's where this data is a little sketchy. And another thing that is sketchy to me as well is the fact that this August 31st, 2022 press release. And if anybody in the chat, or the comments later on has more up-to-date data, I'd love to see it. But I haven't seen any national mortality data since then. And this is sort of going into the Biden years. So it makes me wonder if things have only continued to decline, but because of the media cover-up that we've had of not only the former president's health, but of so many other issues, as if the data is so bad they don't want to release it.
Yeah, it's I don't trust any of these official statistics just because it doesn't square with my own experiences and what other people, and plus we've seen the government just lying about this stuff outright in many cases.
Yeah, no, I totally get it. So that brings us to kind of the next article I wanted to talk about, and sort of the next issue that I think goes back to your original story. And that is trust in physicians and hospitals, pre-pandemic to post-pandemic. So, Matt, what was your level of trust in doctors growing up? Did you have a favorable opinion of medical professionals when you were growing up and into your early years? Sort of what was your perspective on medicine and the medical profession when you were younger?
I was I like doctors. Well, maybe like is a strong word, but I generally respect them. Like I didn't have any reason to disrespect them.
Yeah, and I think that's probably the general sentiment that most Americans probably had. Now, I asked the question now, like, where is your trust in physicians and within the broader U.S. healthcare system now as an adult?
Probably on the same level of the homeless guy outside of Times Square ranting about the apocalypse.
That's a good comparison. But what do you think and once again, the loaded question, do you have any idea as to, sort of the degree of decline in trust of physicians that has occurred in the past 5 years?
I'm vaguely aware of it, but I don't have any stats. It wouldn't surprise me if it was in the toilet.
Yeah, it's gone really down. There's an article, I'll share this one. And I think this goes back to all of the various issues that we've seen. So here's one here. This is actually an article that's been cited by a lot of mainstream sources. I think this was cited in the New York Times and several other large publications. And so this was a very large, just sort of general public survey. I believe there was about 440,000 unique respondents. You can see 443,000, and change unique respondents who answered this very broad-based questionnaire about trust in physicians and hospitals during the COVID-19 pandemic. And what they found is that the trust had declined over the course of the pandemic from April of 2020. Now, I would have loved to have seen this survey, say, July of 2019 until January of 2024, but you can only do so much in anticipating an event like COVID. And so I think it's great that they started in April of 2020, just a month into the pandemic, and they went all the way to January 2024. And there had been a precipitous decline of over 30%. So trust had gone from 71.5% in April of 2020 to just 40.1% in January of 2024. And it says individuals with lower levels of trust were less likely to be vaccinated or receive boosters for COVID-19. And they get into all of their, statistics and that kind of stuff, and sort of long-term, views of, the importance of. Well, let me back up real quick. One of the reasons this is so important is you've had a number of public health initiatives that I believe have saved lives, and others that I think have been sketchy. But physicians have traditionally been like the key representative of not just healthcare in total, but even public health, for things like wearing seatbelts, smoking cessation, diet and exercise. They talk about firearm safety, which that's a very controversial one, but I think we could all agree that physicians have played a very important role in public health messaging. And historically, most Americans probably had a generally favorable view of physicians. Obviously, they've talked about, there's always been sort of, certain segments of the population that haven't had as much trust of physicians. But for the most part, doctors have had a generally favorable opinion by the general public. But that really collapsed during COVID. And it's interesting to see for all demographics, whether male or female, all, sort of ethnic groups and all age categories. Interestingly enough, it seems like Zoomers and Boomers had the highest opinion of healthcare professionals, whereas Millennials and Gen Xers had the lowest opinion. And I think that's probably the effect of politics. But across the board, you've just seen these just precipitous declines in, here's a nice force plot showing the negative impact of the pandemic on physician trust by the public. But I think that because we've had this decline, I think it really puts a lot of future public health messaging at risk. And people are just not going to listen anymore. And I know you've talked about this some, Matt, but what was your take as you were kind of living through 2020, 2021, and you would see people like Tony Fauci and Francis Collins and others get up there and message for the government? How did that impact your perspective on, whether or not healthcare professionals could be trusted?
Probably sent it into the toilet, just because we have, there's a lot to unpack here, but I'll point out something that a lot of people seem to have forgotten. Like, we all remember the whole mask stuff, like, oh, you have to wear a mask, blah, 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 That did not start during the lockdowns. During the lockdowns, wearing masks was encouraged, but it was not mandatory. Even in Albania, there was no law requiring people to wear masks when they left the house. You were just encouraged to wear one. It was not until the summer, when the lockdown started being removed or eased, that you had suddenly, like, you have to wear a mask here, you have to wear a mask here, you have to social distance there, or whatever. The fact that it kept changing and other stuff kept changing really, I think, just destroyed faith in the medical profession. Plus stuff like, the George Floyd happened, right when COVID was about to end. And that resulted in, doctors saying, like, oh, it's okay to go and protest because racism is a bigger public health crisis than COVID. So as long as you wear a mask, it's good. And also the whole social distancing thing, that was different in every country. Well, not every country, but like in America, it was 6 feet. In Europe, since they use the metric system, it was 2 meters. That's not the same distance. 2 meters is not the same as 6 feet. Similarly, when the whole PCR test thing was being implemented, you had to have a PCR test done before entering particular countries. Every country had a different regulation. In some countries, it was 48 hours before arriving, you had to have a PCR test done, a negative PCR test. In the US, for some reason, it was 24 hours. You had to have one within 24 hours. There were countries that required them within 72 hours. There was one country, I think Bolivia, that required having one done within a week. If this was based on verifiable science, why is everything different? Why does every country have a different regulation? Why is all this stuff changing constantly? And this stuff, the average person, they may not know about medicine, but they can tell when they're being lied to. They can tell when the experts don't actually know what they're doing and are just making it up as they go along.
Yeah, I think so. There's a couple other sort of follow-ups I wanted to have to that. I ask you, Matt, in that regard. What role do you think the suppression of the lab leak theory, and I use that in the more scientific sense of the word, the suppression of the lab leak theory, which we now know is in all likelihood the most probable origin of the virus, as well as the messaging around boosters had in that regard?
That was another thing that probably destroyed trust. The concept that this virus was man-made was a definite factor. And I also want to point out how the narrative was. The COVID narrative began in early 2020, and you'll remember stuff like Hug a Chinese Person Day, and the media was saying like, well, if you're concerned about COVID, you're racist. It's racist to imply that this is a man-made a man-made virus from China. And then in March, it suddenly flipped to stay the bleep home so you don't kill grandma. People saw this over and over again, and it just destroyed their trust in the healthcare system.
Yeah. Once again, I'll give you a little inside baseball here. One of my former medical school professors was on the email link, and I had a friend who, very, very smart guy, kind of historically liberal, but maybe a little bit more left libertarian. Maybe I'll send this to him. I'd be interested in his take. He's now an infectious disease doctor. Got a Fulbright scholarship, was down in Brazil, kind of an Indiana Jones type, sort of a Jack Kerouac, San Francisco white guy with kind of a libertarian streak. But one of his, I guess, primary investigators, the professor who's over him for his research when he was in fellowship at the University of California, San Diego. I believe that was Christian Anderson. You had guys like Francis Collins, Bob Gary from Tulane, Christian Anderson from UC San Diego, the guy from UNC Chapel Hill, who I believe employed the Bat Lady as a postdoc, along with Fauci, that there were email leaks. And if anybody in the audience, wants to post this, I'm pretty sure that this has been exposed. And there was somebody who won some sort of journalistic prize. I'm trying to think, it's like a year and a half ago this story came out. Basically, that they knew very early on that the lab leak hypothesis was not a joke. And in a lot of ways, they were looking at the structure of the virus, and they said the probability of this coming from like a pangolin or civet cat or whatever was very low. And clearly the proximity of the so-called wet market to the essentially the Chinese version of the CDC there in Wuhan, along with the fact that we had this kind of research being done inside the United States, but it was intentionally moved overseas, which is something that I think the NIH is engaged in. You see this in Ukraine as well, with the so-called biolabs that I'm sure you're a little bit familiar with, Matt, having lived in that part of the world.
Yeah.
I think that the highly unethical behavior of our public health leadership, especially in guys like Francis Collins, who I know was used by evangelical organizations like the Gospel Coalition to essentially cover for the Biden regime, was very, very negative. But some of the highest people at the top, the very top, knew from the beginning, and this was intentionally suppressed. And now this is coming out. Additionally, the mandates for the vaccine, I think, was another big issue. It's not just that the vaccine was available; it's that you had this, incestuous relationship between large corporations like Pfizer and the federal government that received hundreds of billions of dollars in essentially liability immune money from the feds under emergency use authorization to create these vaccine products. And the number of randomized controlled trials done, especially for the boosters, I believe to this day is zero. And forcing the public in a sort of sweeping, broad, top-down way without any consideration of prior infection, of age, of all of these other issues, really damaged the public's trust. And I don't know if we're ever going to get that back. I remember another little inside baseball thing for me, Matt, where I was working at the time. I remember the EHR, and this is kind of the Orwellian aspect of the EHR, and why I have a friend he was from the Triangle area originally, and now he lives in the rural Midwest because he's one of these prepper types who thinks that every state is eventually going to be a blue state due to demographic change, and you need to be in a red county more than anything else. So he moved to 95% non-Hispanic white rural county in the Midwest, intentionally seeking a place where there's no population growth and where he could have a physician who's actually, surprisingly enough, not on an electronic medical record, or it's a very stripped down version of it. When I talked to him about the concept of a national patient identifier, which everybody says is like the holy grail of like a health information exchange, he immediately recoiled, because he's like, yeah, that's exactly what they do in China with like the social credit systems. Because if now all of a sudden you have a national patient identifier and you're not up to speed on all of your COVID boosters, they can deny you all sorts of healthcare services. You had all of these stories about this young girl who wasn't vaccinated, who was like denied a kidney transplant in Colorado. But I remember where I was working prior to that state coming out with a booster mandate. I'm not even talking about the initial vaccine, but a booster mandate. This is prior to it being announced, and they were saying publicly, oh no, there's not going to be any booster mandate or anything like that. I saw the notification in patients' charts that had already been built in of essentially a flag that this patient had not been boosted. And that was before the booster mandate had like even come out. So I think a lot of people were already preparing and maybe had inside knowledge from government actors that this was coming down the pipe. And, publicly they would say one thing and then privately they would say something else. So sorry for the long monologue and the rant, but any thoughts on that?
Yeah, that, I mean, I don't have anything really to add. You kind of took the words out of my mouth. It's just, pretty, pretty awful situation. And I agree that it would take a very long time for the healthcare system to rebuild trust in the eyes of the people. And we're talking like a 10, 20-year time frame. Because the old adage, it's much easier to create than to destroy. I mean, it's much easier to destroy than to create. Got that mixed up. Basically, all the credibility that the medical system built up over decades was wiped out in COVID and everything else that's happened since then. It was not great before then, as you pointed out with the private practice issue, but it got really bad, and it's going to take a long time to reset that.
Yeah. Well, we have about 20 minutes left, Matt, and I just wanted to jump into the last couple little things to get your take on some of these issues because, one, I think the current state is driving the best and brightest out of medicine. And we'll get into a couple of articles here. And then secondly, what I don't think a lot of people in my profession, especially who are more left leaning, and medicine has been increasingly trending leftist as the decades have worn on. I think you probably see that as much as I do, maybe even more so from the outside. But there is a judgment day has come in a large form with the reelection of the Orange Man Bad and his picks for the NIH director and the FDA, which has caused quite a stir. And so we'll get into that in a little bit. But I wanted to talk about the foreign physician issue that we brought up at the very beginning. And I'll just share this article with you and with the audience from NPR, of all places, very trusted news source. Totally unbiased, of course. So here is an article that was from just a couple of months ago, and this is coming to a small town near you. So to solve for doctor shortages, states ease licensing for foreign trained physicians. And so this is this guy who I believe is from Afghanistan originally. Nothing against any particular individual physician, but I think it's important to highlight the national trend. So it says a growing number of states have made it easier for doctors who trained in other countries to get medical licenses. A shift supporters say could ease physician shortages in rural areas. The changes involve residency programs, the supervised hands-on training experience that doctors must complete after graduating medical school. Until recently, every state required physicians who completed a residency or similar training abroad to repeat the process in the U.S. before obtaining a full medical license. Since 2023, at least 9 states have dropped this requirement for some doctors with international training. According to the Federation of State Medical Boards, that's the FSMB, they handle all of the like USMLE and medical transcript stuff whenever you go to apply for a state license. About 26% of doctors who practice in the U.S. were born elsewhere, according to the Migration Policy Institute. They need federal visas to live in the U.S. plus state licenses to practice medicine. Proponents of the new law say a qualified doctor shouldn't have to spend years completing a second residency training. Opponents worry about patient safety and doubt the licensing will ease the doctor shortage. And they talk about, Republican versus Democratic states that have done this, Florida, Iowa, Illinois, Louisiana, Massachusetts, and so on and so forth. The changes come as President Trump moves to tighten many immigration rules, although he has defended a federal H-1B visa program that many foreign doctors rely on. Supporters of the new licensing laws include Zalmay Afzali, an internal medicine doctor who finished medical school and residency program in Afghanistan before fleeing the Taliban and coming to the U.S. in 2001. He said most physicians trained elsewhere would be happy to work in rural or other underserved areas. I would go anywhere as long as they let me work. I missed being a physician. I missed what I did. It took Afzali 12 years to obtain copies of his diploma and transcript, study abroad for exams, and finish a 3-year U.S.-based residency program before he could be fully licensed to practice. But a commission of national health organizations questioned whether loosening residency requirements for foreign doctors would ease the shortage. And they talk about the licensing and employment barriers. There's this public policy guy. He said, I think the potential is there, but we need to see how this pans out. Anyways, there's a lot of, controversy about this proposal. So what are your thoughts, Matt, about this push for allowing foreign doctors to be able to practice in the United States without first having to complete a U.S. medical residency?
Well, I mean, get used to more DPIC already if that's the case, because as I discussed earlier, you have the case of massive plagiarism and outright degree fakery going on in these countries. The reason why we require doctors from other countries to retrain under our system is so that they follow the rules of our system, because different countries have different standards. You want to make sure you want to have a foreign doctor come here. They have to be operating according to the standards of the American medical system. This is basically like the H-1B version, the medical version of H-1Bs. Like, we'll bring in people who are very unqualified, and to address a supposed shortage that either doesn't exist or was outright created through bad regulation and bad policy.
Yeah, I think that there's a couple of points to be brought, and that's that if we were to implement this policy, who's going to track their performance to see if this actually improves patient outcomes? Access to healthcare doesn't necessarily mean improved quality of life. It has to be access to quality healthcare, to good healthcare. To your point about the Dr. Reddy situation there in Syracuse, that woman harmed more patients than she helped. And so was it a benefit for the public to actually have her practicing in the United States? And what kind of verification system are we going to put in place for these foreign schools? Like you said, you have all these degree mills, whether it be in, post-Soviet countries in Eastern Europe, or especially in the subcontinent, even in a place like China, where, cheating and, sort of government nepotism and bribery are notorious. Those are all factors that it's like, well, are we going to be monitoring this stuff? Are we going to run randomized controlled trials, which is the gold standard of evidence, to see if these physicians are actually performing up to snuff? Something tells me that we're not going to do that.
Yeah, it's just going to be like, here's Dr. Ramesh, who got his degree from the Medical University of Bangalore, Highway 13, located in the rest stop next to the KFC. That's basically what it's going to be. It's just going to lower standards and lead to more harm to patients, and further degrade trust in the healthcare system. Yeah,
which we already have. A lot of domestic issues, which I'll go ahead and share there. And I'll put some of these links in the show notes for everybody to look over as we wrap up here in the next 10, 15 minutes. Here's just an X post that I think you'll find interesting. Have you seen this graph before, Matt? In terms of medical school acceptance rates within the United States?
Oh, yeah, I've seen that.
Yeah. And there's some other posts. This Mark J. Perry has put out some really good stuff on this. But this is under the old system where the MCAT was graded on, I think, a 0 to 45, like a modified score. And basically a good MCAT score, especially with like all the testing companies and that kind of stuff, you've kind of had inflation of the MCAT score over time. to where a good MCAT score used to be back in the day, maybe 27, 28. 30 was considered like, okay, if you got a 30 on your MCAT, that means you're probably, pretty well qualified to be a doctor. Anything like 33 and above was like you're basically a shoo-in for the most part. But as you can see, this is a result of the Backey decision. Which, do you remember, Matt, the details of the Alan Backey situation?
Refresh me.
So yeah, this is something for the public that they need to know. Back in 1978, I believe it was the University of California. Irvine comes to mind, but I don't think it was Irvine. I think it was UC Davis up in the Sacramento area. I have a friend who he had a brother who graduated from UC Davis. But Alan Backey was I think a veteran. He was a white guy, kind of square guy, glasses, double bridge, that kind of stuff, who applied to admission at the University of California, Davis, and was rejected by UC Davis initially. And he had a really good GPA, was a veteran who I believed had served in either the Army or the Marines, and so honorably discharged, had a good MCAT score, and yet he was rejected at least once, and I think potentially multiple times by the state medical schools there in California where he was from. And somehow he was able to find out under California's affirmative action laws that there was a guy that he was compared to. And there's this famous New York Times article from like 1992, 1993 of the guy who was let in over him, who was a black guy who had a lower GPA and a lower MCAT score. And it was comparing the sort of fallout of the Alan Backey decision. And what happened is that he ended up going to I guess all the way up to the U.S. Supreme Court. And they basically said that while race could not be a determinative factor in a candidate's accession to medical school, that it could be a factor that admissions committees could use. So they had a chance to deal a death blow to affirmative action in the late 70s. But it didn't actually change the law. And I think years later, they looked at the physician that he was compared to. And this guy was like an OBGYN or a family practitioner in Los Angeles. And he ended up killing several patients, like just grossly incompetent, had to like have remedial courses. And I think ended up like dying an early death. I don't know if he was murdered or he committed suicide or something. And they compared him to Alan Backey, who I think ended up working in private practice as an anesthesiologist for like over 40 years. And, ended up having a very successful long-term medical career. And I think what that case highlighted is the fact that even as early as the 1970s, we knew that we were taking in less qualified minority candidates. And that's what that graph that I showed on X is showing, is that whites and Asians in particular are being actively discriminated against and have been actively discriminated against in medical school admissions. Not just in terms of acceptance rates, but I mentioned the scholarship issue earlier. To where they can graduate with a higher debt burden because of the lack of availability of those kind of scholarships that are only available to certain demographic groups. And so you've seen, I think, a decline in the quality of physician as well, because it's just not as profitable to go into medicine as it once was. And When you have active discrimination against some of the best candidates, people who otherwise would have gone in and contributed their bright minds to medicine are going off and working for like Tesla or investment banking or becoming content creators on the internet.
Yeah, I mean, I want to highlight the profitable part. This was actually a major concern when Canada implemented their Medicare. That's the term they use for their socialized medicine back in the 60s. It was first implemented in Saskatchewan and then later rolled out nationwide. And the concern from physicians and people who oppose this policy is that it's going to make being a doctor far less viable, factoring in debt and all that. And a lot of doctors will just end up going to the U.S. Because they can make more money. And to a certain extent, and to a very large extent, that's what happened. A lot of Canadian physicians just ended up moving to the U.S. And the profitability, obviously, maybe if your profit is your sole motivation, you probably shouldn't be going into medicine or any such field. But the debt issue is real, and people with skills need to be compensated appropriately for those skills, particularly if it takes years and years and hundreds of thousands of dollars to get them. If you end up in a situation where we've created a situation where being a doctor is no longer is much more financially unsustainable. And now that this problem's been created by Obamacare, they're like, oh, we'll bring in more foreign doctors, which is very much hair of the dog, really. It's literal hair of the dog. It's injecting, it's causing more problems.
Yeah, and there's another issue here for our old manosphere crowd who like to talk about feminism. There's another issue, and this is from that evil, wicked white supremacist Steve Saylor from a 2023 article, and he writes, "A new problem: not enough male medical students." And so he goes, actually, it's not just the race issue. It's that you actually have an increasing number of women. And as you can see right here, here's 1980, 1981, and here's 2022, 2023. And it's the number of medical students as a whole. And you've seen a decent, trend of where there's been a few thousand extra doctors, every year that we matriculate than we had in 1980, which makes sense given population growth. But notice this line right here. And that is the number of male matriculants has actually decreased since 1980. There were more men admitted to medical school in 1980, 1981 than there were in 2022 and 2023. And look at this line here. Almost a straight upward tick, and that is the number of women going into medical school. So, Matt, you may know this, and I can throw it out there for the peanut gallery, but why might it be a problem that the ratio of male to female doctors has now reversed from what it was historically, and that women now are more likely to become physicians than men?
Well, I mean, there's a whole bunch of problems, but I could see, with regards to the COVID hysteria, a lot of women were driving that one out of sheer paranoia. Common Filth used a vulgar phrase to describe it that I won't repeat here. But if you want to, and since you mentioned the manosphere, well, it's the whole hypergamy thing. I guess that's another issue.
Yeah. Well, here's just a straight brass tacks from the economy, and Saylor comes out and says it right here. The problem with having fewer men doctors is that men tend to work harder at doctoring, whereas a lot of female doctors downshift their careers when they marry, often to a male doctor, and have kids.
I completely forgot about that. Sorry.
They won't have kids, which is a shame since they are high human capital. So that's a big problem on a macroeconomic level, is if you're training, we say we need more healthcare professionals, but we're training more women than men, and yet women work fewer numbers of hours, work fewer numbers of years. And I know female physicians out there who work many long hours and many, long careers, but we're talking once again population averages here. And I tell you, even the women that I have seen, many of the women that I saw who were attendings in my training program had been divorced. And to me, it's not surprising why. Having gone through what I've gone through, the fact that I have a stay-at-home wife, if my wife was not able to stay home with our kids, I honestly don't know if we as a couple would even be able to say that we raised our kids in the proper sense of that term. They'd be just shuffled off to daycare. And yeah, it's a big problem. I had one colleague a number of years ago, very successful, has since gone to locums work, and she married another physician. And she said, I guess, she'd come to the mid-career point and she's downshifted. And she's like, I don't even know why I went to medical school in the first place. My crazy friend who moved to the Midwest said that the thing about most female physicians, and I think he said all, I'll say most, being more charitable than him, but he said they've hit a bullseye on the wrong target of life.
Interesting. That's an interesting way to describe it, but I'd largely agree. And that's a good point you brought up that I had completely forgotten. That men are more likely to build their careers and focus around them, whereas women generally don't. When they have kids, when they get married, they start trying to move off the responsibilities, as they should to a certain extent. I mean, to raise your kids, but it creates But if there's more female doctors than male doctors now, that means there's going to be an even more bigger shortage. The shortage of qualified physicians is going to be even worse.
Yeah, and hence the demand for more foreign physicians is going to go up. So as we wrap up here, Matt, just sort of the last thing, it seems like there has come at least a partial day of reckoning with the Trump administration. He hired Jay Bhattacharya to be the head of the NIH. He's the guy that authored, one of the main authors of the Great Barrington Declaration during COVID, which was the targeted protection model. He was also the author of the paper that was the first prevalence thing that basically said that the mortality rate was much lower than was actually reported because the disease was much more prevalent. And Dr. J caught all sorts of hell when he was at Stanford, especially being a member of the Hoover Institution. And then Marty McCary, who has been put in charge of the FDA, was a surgeon at, I believe it was Johns Hopkins where he was at. And he'd written a number of books talking about the problem with the COVID boosters and the sort of one size fits all thing. And then obviously with RFK coming in, there's been a big shakeup there. And so as we close up for the night, Matt, where do you see healthcare going in the United States, from your sort of perspective? Do you see any improvements on the horizon? Do you think that the Trump administration is going to have any sort of positive effect, or do you think we're going to continue to see the negative effects of Obamacare and increasing foreign physicians and the continuing trend of women outpacing men? Where do you see things going as this Trump term evolves and as we head towards 2030?
Well, I see a lot of positive developments. I think RFK's Health and Human Secretary is a very good thing, and Jay Bhattacharya, I probably mispronounced his name, as you mentioned. People who are very skeptical of the whole COVID hysteria and very critical of the vaccines, the lockdowns, all of that. Particularly with I saw there were some people complaining about how the government has now, under RFK, has now restricted advisories for COVID vaccines to certain demographics, and also required that the vaccine manufacturers disclose the health risks for young men and other demographics who might be harmed by them. And there are people complaining about that. And it's like, look, if you still want to take your precious shot, you can. There's just new guidance available. Now, in terms of rebuilding the trust and the efficacy of the American healthcare system, that's a long-term project that will extend beyond Trump's term. But we are seeing positive action on this and on many other things from Trump. That gives me hope. I'm not going to stake a definite prediction, and I'm not going to be hopelessly optimistic, but I am optimistic.
Yeah. I'll say some of the things that I think need to happen from my perspective. This is very controversial in my circles, but not necessarily in the circles that we run in. But I think mass deportations is a must. If you look at the economic numbers, illegal aliens cost our country far more than they add. You look especially at certain healthcare systems in places like Arizona, New Mexico, South Texas, have gone bankrupt essentially because of the influx of illegals, especially in the past 4 years under the prior regime. I think that, especially when you have states like California talking about giving free healthcare to illegals, this is just unsustainable. And so I think you need to have mass deportations. I think that going back to a merit-based system where race is not a consideration at all will lead to a higher quality physician. I think that there needs to be deregulation. And as somebody who actually, has some experience in the area of EHRs and that kind of stuff, I actually think you need to have deregulation of things like the HITECH Act and need to allow especially small practitioners to not have to meet these standards, especially since we have no evidence that they actually lead to an increase in life expectancy.
We could argue that they do the exact opposite, given that, life expectancy has gone down.
Yeah, exactly. And so these are, I think, some of the solutions that need to happen. The problem that we're going to have, and I think it's good with the new anti-DEI measures that are coming in. Much of the reason for the bloat in the cost of both healthcare and in medical education, which is inflated at a rate even beyond college education costs. And if you want to keep costs down for medical students, Trump limiting grad plus loans and the amount of federal loans people can get, that's going to force medical schools to start cutting all of the DEI administration and the administrative bloat that they've become notorious for. Physician salaries are not the reason that healthcare costs have gone up. It's all the administrative bloat that has happened. Much of it very antithetical to us and to our particular way of life of thinking with the DEI apparatuses that so many folks have and the make work jobs that so many people get. Just because it keeps people employed. But I think a lot of that stuff needs to go away because those jobs don't actually contribute to the primary mission of serving patients. And I think that the anti-DEI measures and Trump cutting all the NIH funding as well, that's going to have a real positive impact. And it'll be interesting to see what happens. I know the big beautiful bill is not going to affect me, but there is a push to limit public service loan forgiveness for physicians, basically saying you can't count your residency time towards PSLF at this point, which means most doctors will have to wait somewhere between 13 to 17 years instead of 10 years after graduating in order to have the balance of their loans forgiven. And what I think that could end up happening is it could end up, causing a chain reaction for the medical industry and the medical profession to start tightening the belt and actually being more focused and mission critical because all the government cheese is going away. So, any final thoughts, Matt, before we go for the night?
That's I mean, that kind of sums it up. Aside from a generic, I don't know, trust the plan, I guess. Like not the Q plan, but like the Trump administration has been doing so much good on this and many other fronts. I see no reason to be unhappy at this moment in time. This is what winning feels like. This is exactly what it feels like.
Yeah, I totally agree. So, well, brother, thanks for coming on the show tonight and for hanging out with me for a little bit. I know you got to run and I got to run as well, but love to keep interacting with you on X. Would you like to let the audience know how they can follow you and find you on various social media platforms and some of the stuff you're up
to? Just follow me on Twitter. I refuse to call it X. It's x.com/show Matt Forney. That's the platform where I post most stuff, and it's also the platform where I have the most reach. So like anything new I'm doing, you're gonna find it there.
Cool. Well, I'll repost the show on X after it's done and tag you. And once again, thanks for hanging out even after all these years. It's good to see that you're doing well, and I was really happy a few months ago to see that you were back on X and remembered that show that we did about the Southern Baptist Convention all those years ago. And let's just say that it continues to be a field of battle within the SBC. And, I was actually out of the denomination for a little while in a more traditional Reformed Baptist church. But now I'm back in a church since I moved for work that is in the SBC that's more conservative. And we'll continue to see how that battle plays out. But anyways, thanks for joining us tonight, folks. And, like, comment, and subscribe. And we are out. Thank you.